Our next speaker is Dr. Wharton. Dr. Wharton has a doctorate in pharmacy and medicine. He's a medical director of the Wharton Medical Clinic, a community-based internal medicine weight management clinic. He's an adjunct professor at McMaster University in Hamilton and York University in Toronto. He also works as an internist at Toronto East General Hospital and the Hamilton Health Sciences. Dr. Wharton is a researcher. He is qualified as a diplomat of the American Board of Obesity Medicine. There are only a handful of Canadian physicians with this qualification. Dr. Wharton's focus is on bariatric medicine and type 2 diabetes, and he's the lead author of the weight management section of the Canadian Diabetes Guidelines.
Thanks. Terrific to be here. I can't believe there's so many people here at 8 o'clock in the morning. You guys know how early it is here? This is great. So I have the honor of following my colleague from Boston, from Harvard. I'll let Usman know that actually I think Toronto's bigger than Boston is. Even we don't have as much of the academic merit, but we are trying. So my charge today is to give you a little bit of the scientific hormonal kind of academic components of what we're seeing within the field of bariatric medicine. And so I'll follow with, I'm going to give less of a practical view, a little bit of a practical component, but certainly a little bit of the research and where things are going and what we have available here in Canada and in Ontario for this current problem. And so here are my disclosures and mitigating potential biases. Okay, so since the Heart&Stroke Foundation, I thought the first thing we do is we talk about what are some of the cardiac components. And so this is a database looking at 1 million patients. If we look at the rise in BMI, we'll see that the all-cause the mortality goes up as the BMI goes up. This is no debate or question for most people. Question is what is it that causes this increase in mortality as the BMI goes up? What diseases are killing patients? You can see that the biggest group of diseases with the hazard risk ratio are ischemic heart disease, stroke, and other vascular diseases. So heart disease is causing the death as BMI goes up. Diabetes is even a higher risk factor, 2.16, but we can see that heart disease is certainly one of the bigger factors, and the attributable risk is certainly very high. So this is out of Boston. Harvard started looking at the attributable risk for an increase in BMI. In the gray, that's the people who are in the overweight category, and in the black, that is the people who are in the obese category. If you're over on the right-hand side of the graph, there's an increased amount of death, CV death or cardiovascular medical conditions. So you can see that for men, which are in the top row, the gray is more predominant than the black is. So when you're in the overweight range as a male, you're at relatively higher risk even than some of the obese ones. The obese are higher, but you can see the attributable component is very big in the overweight range for men. Now let's go down to women. You can see that the overweight range in women sometimes is on the left side of the graph. There's a protective component. Its majority of it is still in the increased risk side, even in the overweight and in the obese, it certainly becomes more so. So what is this component of this protectiveness that may happen? And we'll talk about this in a bit, but it's mainly likely because of the peripheral fat or brown fat. And so we know the visceral fat causes the medical problems, and some of the peripheral fat in the hips and in the thighs, the brown fat, which is more of a thermogenic fat, doesn't cause as much problems and is more of a protective manner. So now, overweight, BMI between 25 and 30, is this greater in men or is it greater in women? Women, here in Canada, this is Canadian data. So how many people for overweight, 25 to 30, higher in men? How many people higher in women? Okay, most of you said women, and you were wrong. It's men, and men 42% versus 30%, and there's more of this android of the apple shape, which is what we were talking about, right? That overweight component, that hard belly, is where the medical conditions are going to come from in the metabolic syndrome, of course. Now, and this is all the visceral fat versus the peripheral fat that I was talking about. The peripheral fat has more brown fat and doesn't cause medical conditions. So if you've got that, obviously, the visceral fat, it goes into the liver, it causes, and we really believe now more so, a lot more research coming out that that fatty liver is where diabetes actually comes from. There's a whole lot of components of that's actually happening. It's not just a mechanical condition, and we always knew it was a metabolic condition, but the degree of the metabolic condition that we're finding out now is much greater than we thought. Of course, and this is because the fat cell is not a inert cell. It's a metabolically active cell. We didn't know this up until about the past 30 years or so, but we know that many of the markers that come from the adipose cell are similar markers that come from cancer cells, that come from all inflammatory markers or cells that we think about when we think about stroke and heart disease and many other medical conditions. And so now, morbid obesity, a BMI greater than 40. Is this greater in men or greater in women? How many people for men? And how many people for women? Okay, I think you more said women, and now you're right. So it's more than double. And this is the gynoid shape or the pear shape that we see. There's less cardiometabolic conditions as a result of this. You can get mechanical conditions, of course, arthritis, urinary incontinence, fatty liver. Certainly, so we know that this gynoid shape or this curved hips and thighs, smaller tapered waist due to more so estrogen, and there's a lower cardiometabolic risk. It is hard to lose that fat from the buttocks and the thighs, but it's maybe because it's a protective fat or it has certain positive components to it. Now, what we know is, and this is important because African American women are the predominant group in the States that have the highest weight components. If they have the highest weight, are they in a lot of trouble or a little bit of trouble? Well, what we've shown, Dr. Sumner showed, Ann Sumner, I'm sorry about that there at the bottom of the slide, you need to get up to higher BMIs in African American women to show a real problem. BMIs of almost 38 or BMIs of 32 for insulin problems, and that's what that says, waist circumference of 98 or BMI greater than 32 at the bottom there. So because we know that when the fat first starts to come on, it goes into the buttocks, it goes into the thighs, and that's where then you don't have metabolic problems there. Once you start going over that range is where you start to end up running into metabolic problems. So if you've got thighs, if you've got hips, don't worry about it. Everything's good. Any reason to put a picture of Beyonce up, I'm very happy to have. And so I don't have a problem there. When we start to run into trouble is because African American women, states don't stop at a BMI of 32 or 35. They go up to BMIs of 45 and 50. So it's almost in the 90% range that African American women are in this range in the states in terms of the overweight to the obese range. So here we have Gabby, who's a movie star, and BMI 58. As she gets older, things are going to go poorly. She was young and there's not as many medical problems, but as things go on, because of course now she doesn't just have the fat in the thighs and the hips and the buttocks, but it's also in the belly now. So what type of weight management could she possibly look at? So this is some research that we did at our clinic. So this is 7,000 patients that we looked at over 7.5 years. None of these patients had bariatric surgery. None of them were on any medication. So we run an academic center that is an OHIP-based center. It's open to all patients who can come. It's an internal medicine-based center. It's part of the Ontario Bariatric Network. So there's no problems with access to care. And as Osman had pointed out, we have a universal health system here, so it works out well. So with an academic center, we looked at how patients were able to lose weight, and they were allowed to put themselves into a trajectory of weight loss. Instead of just looking at the weight at the beginning and the weight at the end, we looked at what was their pattern. And you can see here that the majority of patients fell into the weight stable or the minimal weight loss, the purple line or the yellow line. And so, and you can see there were less people that fell into the large amount of weight loss, the moderate amount of weight loss, the weight loss and then regain, but then slowly coming back. So about 22% are in in that weight loss category that are keeping it down over a longer period of time. So certainly we were happy to see that that a lot of our patients didn't go up further in weight, but certainly I can imagine that the majority of our patients would not like to be in that purple or yellow line, but would rather be down further in the greater amounts of weight loss line. And why can't we get patients to lose as much weight as we actually want them to? Because we know that obesity is a chronic, and this is the most important slide on the slide deck, progressive, relapsing medical condition. If you forget this, then you'll forget what obesity is. It does not go away. It's chronic, just like congestive heart failure is chronic. You can control it, you can take care of it, you can symptomatically treat it, but likely the chance is that you'll die of congestive heart failure. You'll die with it. It's there. It's chronic. Obesity is always with a person, never goes away. Progressive nature. Everybody gains weight every year. So there's likely nobody in this, very few people in this room that are lighter than they were 5 years ago. So even if it's at 0.1 pound, 0.5 pounds, we slowly go up every single year. We do a lot of work just to stay the same weight. We go to the gym, we eat properly, and if we're able to stay the same weight 5 years from now, that's a big deal. It means you worked really hard. And so if you don't work hard, then the weight naturally goes up and up and up. The relapsing nature, it comes back if you take your foot off of the gas. Okay. And why is this? Because our bodies defend our highest weight. The biological process is set that we're not designed to lose weight. We're only designed to hang on to weight and potentially gain. Or else we wouldn't be having this conversation here today, because we wouldn't have made it as a human species. And so, but if we look at lifestyle modification studies, this is a meta-analysis from a long time ago, 2001. The reason why I put this up is because the meta-analysis and the data hasn't changed, so I like using it. So 13 studies using meal replacements and a number of other dietary measures. Patients were able to lose weight over the first 6 months period. Easy to lose weight over a 6-month time frame, right? 14% decrease in weight. The question is how much weight can you keep off over the 4 to 5 year time frame? So what percentage of weight do you think on average in this meta-analysis people were able to keep off over the 4 to 0.5 year time frame? So it's a 3% average weight loss. And that's what we see as the placebo in most weight management trials. So if you have a medication or a surgical trial, particularly a medication trial, you'll see that the placebo arm, which is lifestyle modification, intensive lifestyle modification, it's about a 3% weight loss. And so that's what we end up getting. But most people will say, well, you know what, I've got a better plan, there's a better way to do it, I can do it. So more and more studies, and this is a number of our gurus within the field, so over a 6-month time frame, the weight comes down. But then if you look at those patients, follow them up 4 to 5 years later, this is where the weight goes, right? The majority of people float back up to a higher weight. Why do you float back up to higher weight? Because that's the way it goes. That's the biology. And we can't deny it. We can't avoid it. But what does lifestyle modification do? It's very positive. And the DPP out of Boston showed this, and multiple other studies have. This is my study, and we looked at about 300 patients in this sample here, where we're looking at the patients in the clinic who lost greater than 5% of their weight. They were able to decrease their blood pressure. That's on the far right side. So their blood pressure came down nicely. What about those that didn't lose 5% of their weight? Their blood pressure came down also. Their HDL went up, their LDL came down. All the metabolic parameters went in the right direction regardless of whether they lost weight or they didn't. Why? Because of all the things that Dr. PharmD just spoke about, because all of those parameters of lifestyle modification, the most important things you can do. Even if you don't lose a significant amount of weight, if you can move more, if you can exercise your muscles, if you can rip muscles so that you can put energy into them, if you can do cognitive behavioral therapy, eat a little bit better than you did yesterday, everything gets better. So lifestyle modification is our foundation. So now let's talk about this idea of weight, though, above and beyond medical conditions. So hunger is a reaction to a low level of glucose. If you can't shut it off, weight goes up and up. Appetite is different, but we can shut off hunger relatively easily. Just give some glucose. The hunger ends up coming down. Appetite is different. Appetite's much harder. It's a higher neurological center. So it works up much higher in the brain. There's psychological components, etc. And that's the hard one to shut off, because it doesn't shut off with glucose. So feeling full is the answer that we need for weight management, right? If you have this feeling of fullness, then you can end up shutting off the hunger. How do you get this feeling of fullness? It's not just a glucose feeling of fullness or a belly feeling, but it's a psychological feeling as well. And so we know that it's all controlled up in the hypothalamus is where the main mechanisms are. And we know that there's scar tissue in the hypothalamus. If you get to 350 pounds, there is an inflammatory gliosis that happens in the hypothalamus that stamps 350 pounds. So if you try to go down to 320, that scar tissue and that inflammatory component pushes you back up to that 350 pounds. Now, we know that the short-term weight changes may not lead to long-term hypothalamic changes. I had to put this slide in because everybody always asks me after the presentations, what about pregnancy? Am I going to, etc. So that shorter term, it's not as much of an inflammatory change or a movie role, gaining weight for a movie role. So what are these hormone factors? So we know that the main factor that increases hunger is ghrelin, and then there's a number of other factors that make you feel full. And we needed these factors back 10,000 years ago to make sure that you stopped eating enough to be able to run and catch the next water buffalo. So these are all, the good ones are on the bottom. If we can increase those, that's a positive thing, and the bad one is on the top. So the way this works is that any time you decrease your caloric intake, if you're eating 2,500 calories and you go down to 2,000 calories because you want to actively lose weight and do a good job, the brain, the hypothalamus, does not interpret it as that. It interprets it as the fact that you're taking in less calories than you did yesterday, and it doesn't like it because it means that you can't find food. It means you must be in the jungle and you can't find food properly. Therefore, it's going to decrease the metabolic rate and go into a conservation mode. So as soon as you decrease your calories, you're fighting, and that fight will never stop. It has to continue, or else the weight does not stay off. And that's why everyone in The Biggest Loser has regained weight. Everyone in The Biggest Loser has regained weight, right? Because they've decreased their metabolic rate, and as a result of decreasing their metabolic rate, and they did it in such a severe manner that they rocketed back up in weight, and their metabolic rate hasn't even recovered. So this guy gained all of his weight back, and he's eating less calories than a man half his size because his metabolic rate hasn't come back yet. So let's talk about one of these hormones. One of these hormones is called leptin. Leptin is a good hormone. It comes from the fat cells. It tells the fat cells, I have enough energy, I've got enough fat cells. It goes to the brain, tells the brain to stop eating. So people living with obesity, do they have a lot of leptin or a little bit of leptin? So it's a good hormone, tells you to stop eating. How many people for a lot of leptin? How many people for a little bit of leptin? Okay, it's good to be wrong because then you'll always remember what the answer is. It comes from the fat cells. And do people living with obesity have a lot of fat cells? Absolutely. So they have a ton of leptin, a ton of leptin. So what's the problem? Leptin resistance, right? Because can anyone else think of another hormone where there's a lot of it around and there is resistance to it? Right, of course, insulin. And what do we eventually end up doing with people who are very far along the way with diabetes? We give them insulin. So because you were actually right. And when you said that there's a little bit of leptin, there's relative leptin deficiency. Same way there's relative insulin deficiency, so we end up giving insulin. So at the end of the day, are we going to be able to give leptin? Absolutely. So it was a Canadian who founded leptin and found the hormone. He was in Boston when he did it, but he can come from here. Right as of today, we don't have a good molecule that works in the body properly. But soon we will have a leptin molecule that works properly. So in terms of treatment options, so we know that the baseline treatment is behavioral modification, and we have to add pharmacotherapy or surgery. I'm going to skip straight to surgery. Surgeries are gold standard, and so we know that the gastric bypass and the sleeve are the surgeries that help people to decrease weight and keep it off over the long term. Those who qualify, and it's a neuro-hormonal mechanism. And the lap band does not work. It's a restrictive surgery. There's no neuro-hormonal component to it. So if you take away anything from this, take away that the lap band doesn't work if your patients actually ask for it. So why? We know that on the day of surgery, if you have diabetes, we stop your diabetes meds. You haven't lost any weight on the day of surgery. You may be even a little bit heavier. Some fluid is on board, etc. How can you lose weight How can you stop the diabetes meds? What is going on to have that happen? Well, this is what we think is happening. It's called the Hindgut Theory. We believe that in gastric bypass, when semi-digested food bypasses the stomach and hits the ileum, where the L cells live. The L cells are the incretin cells. When it hits those L cells, it generates a flood of positive hormones, GLP-1, PYY. So these incretin hormones go straight to the pancreas and tell the pancreas, wake up, food is coming in. And that's why the diabetes goes away. The GLP-1 also goes up to the brain and tells the brain to feel more full, to act more like a thin person. Thin people have lots of GLP-1. People living with obesity and diabetes have small amounts of GLP-1. You want to increase your GLP-1. How can you do that? You either do it through bariatric surgery or you do it through medications. And we know that this isn't a theory anymore. My colleague Sue Peterson has showed that immediately after bariatric surgery, we see a rise in GLP-1, a rise in PYY, a rise in CCK, and a decrease in ghrelin. So the good hormones going up, the bad hormones going down. We know that bariatric surgery is the gold standard, but it's not scalable. One, it's an invasive procedure. There's challenges with it. Not everyone fits the criteria for bariatric surgery. So what can we do? Medications. Previous medication, you guys all know this, rest in peace. These ones caused problems. So we're afraid of this world of medications for weight management. But there's a new horizon because we understand more about what's happening in the hypothalamus, which hormones work and don't work. So we now in Canada have 2 medications that work. Orlistat was approved in 1999 and liraglutide 3.0 milligrams in 2015. So we have 2. In the States, they have 6. Right? We are behind the 8 ball. They've got 6, we have 2. And the majority of the new ones that have come out work again in the hypothalamus because that's where the money is, right? If we look at Orlistat, which did decrease weight in this trial, so there is weight loss, but the challenge is that the side effect profile is horrible, right? I mean, when you talk to patients and you say there may be something called anal leakage, they hate hearing that because that's when you're passing gas, but you may not be passing gas. You think you're passing gas, but you're not. People don't like that side effect profile. It doesn't work out very well. Fulminant liver failure is also a bit of a challenge. So this is not a smart medication because it doesn't work up in the brain. It doesn't stop the processes that actually cause the actual problems. We want smarter meds that work within the biological systems and that actually are there to cause the weight regain to actually happen, not just ones that are deterrent medications. All the Orlistat did was deter you from eating extra fat. That's not what we actually want. So we want the hormones, those hormones that I talked about, GLP-1, CCK, PYY, leptin. We want those hormones, and we want blockers of the bad hormones. So this is liraglutide, GLP-1, and this is a clinical trial looking at so the first 6 months, patients lost weight in an independent fashion. They were on meal replacements, or doing their exercise, or doing their thing. This is about the point where things start going south. Their GLP-1 goes down into their boots, they start to decrease their metabolic rate, they start to get frustrated, and they go back up in weight. At this point, we give them the medication. You can see that the weight continues to come down and stays off over the longer term. Again, it's the replacement of that hormone that they are missing. And here's the, I'm going to skip by that, so this is Contrave. And the reason why I had that last slide is because there's variability in the response to GLP-1. This is our patient population. Some patients did really well, lost a ton of weight over on the right-hand side. Some didn't do all that great. So the question is we need more. It's a redundant system, and we need more than just one medication. So introduction of a new medication, one that's over in the States. This will hopefully be in Canada within the next year. This is Contrave. It's a combination of naltrexone and bupropion. You've seen these medications before because they are addiction medicine stuff, right? We've seen it before. So maybe food addictions are the people who weren't having the response in that variable section that I talked about when people were not losing as much weight. So maybe this medication will be a positive component to it. Again, another smart medication, goes up into the brain, works the way that we actually want it to. Okay, so, and my concluding slides here coming up. So obesity treatment, in terms of success, we know that lifestyle modification is the least successful but necessary. Pharmacotherapy is here and surgery is here. Look at those slides. What do those graphs all do? They all start to come back up. So everything comes back up. So you will never, this is not a battle to be won. It's a battle to be controlled and pushed to the limit as much as we can. If you get 10 years, 15 years out of whatever treatment model you actually got, and then maybe adding on another treatment model is what we're looking for. We're looking for suppression of the obesity markers. So in terms of conclusion, lifestyle management, don't give up, right? It's the most important thing we can do. It's the foundation. If patients can stay weight stable, if they can not gain weight, if they can change what they did yesterday and they can move a little bit more, if they can eat a little bit better than they did yesterday, they are going to be the winners. If we need more than that, and we need to get their weight down, and they need bariatric surgery, let's say their BMI is 54, they have their diabetes risk is high, we know that bariatric surgery for both diabetes and weight management is our gold standard, if you fit the criteria. Medications for weight management are here. They're effective and they're promising. Imagine, we know the lifestyle is important, but imagine if you had a diabetes patient, the only thing you were walking into the room with was to tell them how to do better lifestyle. That's all you had. That would be a real problem. And that's what we do frequently with our patients struggling with obesity. We walk into the room with nothing else besides a better lifestyle modification program. You would never do that with a patient struggling with diabetes, right? So and we're in the same model. If you believe that it's a medical condition, you have to really believe it, not kind of believe it. And so I believe that with these paradigms, we can move more of our patients from the purple and the yellow lines into the red lines where there's a significant more amount of weight loss happening. So weight loss is complicated. Eat less and move more doesn't necessarily work. Biologists defend your highest weight and the hormones adjust to try to get to this level. Bariatric surgery and anti-obesity medicines act on neurological systems to increase fullness, and pharmacotherapy is scalable and may be very effective in the long-term battle. Thank you very much.